Okay, it's 4:03. Everybody, thank you so much for joining us today. My name is Sergio Pino Oviedo. I am the current president of the History of Pathology Society, and I'm also a pathologist, thoracic pathologist, and hematopathologist at Duke University in Durham, North Carolina. This year, as part of my term, along with the other officers of the society, we decided to create this new online mid-fall conference. Just a few words about what the History of Pathology is, in case you don't know about it. So it's a nonprofit organization comprised of individuals committed to the history of pathology and allied health fields. It was conceived in 1994 by the famous Dr. Henry Azar and Christian Neselov, who I'm sure lots of you probably even met in person. In 1996 in Washington, D.C., there was the organizational meeting took place where several international renowned pathologists got together to concrete this organization. And since 1997, the History of Pathology Society has been a companion society. And this year, we will have also a companion meeting, which I will give some details at the end of the presentation. Today, I have the pleasure to introduce our first ever speaker to this conference, who is Dr. Frederick Askin. So Dr. Askin, a little bit of information about him, even though he doesn't need an introduction. Well, he attended the University of Virginia for undergraduate with a BA with distinction in English literature and his medical school in 1964. He spent 2 years at Johns Hopkins in the private medical service, and then joined the U.S. Navy as an epidemiologist at Naval Medical Research Unit 4. He then served on the Anatomic Pathology Service at Washington University in St. Louis as resident chief resident and then surgical pathology fellow under Dr. Lauren Ackerman. He spent 1 year in a research laboratory at UC San Diego with Dr. Louis Gluck, who a neonatologist who promoted the use of the lecithin sphingomyelin ratio in amniotic fluid to determine lung maturity. And another year extra time with the famous Averell Lebo, where he studied also pulmonary pathology. I'm sure lots of you people know who Dr. Lebo contributions to lung pathology were. Then Dr. Askin subsequently spent 10 years at WashU before St. Louis, taking a position of Director of Surgical Pathology at the University of North Carolina. Then, after the death of Dr. Joe Eggleston, he became the Director of Surgical Pathology at Johns Hopkins in 1991. And after 2007, he went to the old Baltimore City Hospital, which is now the Bayview Medical Center, and served there until 2019. Subsequently, he returned to UNC, where he is currently a clinical professor of pathology and laboratory medicine. His interests in pathology include adult and pediatric lung pathology, placental and benign GYN pathology, and he calls himself an amateur pediatric pathologist, and he presents his biweekly pediatric oncology conference too. Outside pathology, his interests include spending time with his grandkids and the shows of dogs exhibiting and judging professionally. So thank you very much, Dr. Askin. And without further ado, we look forward to your lecture, and I'm sure we're going to enjoy it a lot. Thank you, everybody, for being here. I will just request everybody to remain muted through the lecture. Thank you very much.
Gracias. Benditos a todos. Well, wait a minute. I think I better stop. I'm not going to do well in Spanish, but I gave it a try. So the Askin tumor is an interesting phenomenon. I must say that with the background, the private medical service no longer exists at Johns Hopkins. The Naval Medical Research Unit number 4 has been decommissioned. So there may be some unifying process here. It doesn't seem to have extended to Washington University, Hopkins, or pathology, or here yet, but be careful. So this is the paper that started the whole saga of the so-called Askin tumor. You can see it was published in 1979 with a cast of thousands, including Rosai, Dick Sibley at Stanford, Pepper Daner, and a pediatric radiologist, Dr. William McAllister. The concept evolved because Juan, who had perfect slide memory, as far as I can tell, realized I showed him a case of a thoracic lesion. And he said, you know, we have several more of these in the file. So my job was to go and look in the file and see what we can find. Dr. Rosai, Dr. Daner, McAllister, Dick Sibley, who's still working at Stanford, and me. The tumors look like this. They're called small round blue cell tumors. These slides are 40 years old, and they are now small round pink cells, but I have a couple more that actually do look sort of blue. Round, relatively uniform, not much necrosis, very little mitotic activity. And it looked like Ewing sarcoma, but it wasn't in a bone. Why does anybody care? Well, at that time, Ewing sarcoma was simply a bone lesion. If it wasn't in a bone, it wasn't Ewing sarcoma. That's what the statements were at that time. So I went to work and did some research using. Here's another one that does actually seem to show sort of neuroectodermal differentiation. There's one more that I couldn't find the slide. I could have presented it to you as an ependymoma with these small round blue cells around a blood vessel. But that one was sort of unique. Again, notice clumped chromatin, very little mitotic activity. So here is the research tool that I used to discover all the slides in our file. It manually operated, and you pull these little drawers open and looked at the handwritten diagnoses by organ system. So I looked in the thorax, anything that could construe the thorax, and found 20. At the end, we found 20 cases that seemed to all represent the same entity. The features that we used in this paper probably don't make any sense, but our feature was, and there's one, this is important, it was not Ewing because it was not a primary bone lesion. And we know that's not right now. And they were glycogen negative. So much for special stains. Ewing's tumors were glycogen positive. These were not. They didn't involve multiple bones. There was a female predominance, and there were no light and dark cells. I'll show you that in a minute, components. We considered the possibility of there could be a lesion that Enzinger had just recently described at that time, which he called soft tissue Ewing's. Not neuroblastoma. By EM, there were no new neurosecretory granules, and the location was obviously unusual. Not rhabdomyosarcoma because lack of cross striations, no myxoid stroma, and nothing by EM to indicate skeletal maturation, differentiation in the tumors that we saw. We considered some other cases. Dr. Gordon Vaughter, who some of you may remember, the very famous pediatric pathologist at Boston Children's, and the first author on that paper was named Teft, T-E-F-T-T. They described a paravertebral round cell tumor that was probably the same thing, although I never could get Dr. Vaughter to give me a definitive answer as to whether he thought they were or they were not. In the end, we found 20 cases. Interestingly enough, 11 were actually in the chest wall. 5 seemed to be pleural based. 1 was found at autopsy in the left atrium, or right atrium. 1 was paravertebral, and 2 were entirely within the lung. So it's, the majority of them were chest wall tumors, but they weren't all chest wall tumors, thus the name thoracopulmonary small round bell tumor. Just for contrast, with what we were working at the time. I was for many years a primary reviewer for the Ewing sarcoma study for the pediatric oncology group and children's oncology group. This is the paradigm of Ewing sarcoma: small round blue cells, light cells, and dark cells. Here we are again. These are the same cell. They even look the same by EM. I'm not quite sure why. Some are dark and some are light, but this isn't a different cell type. Again, clump chromatin, no mitosis, very little necrosis. So you can see why we, thought the main differential was Ewing sarcoma. But where did the name Askin tumor come from? As far as I can tell, this is the fault of blame goes to Dr. Timothy Trish, who's at the Children's Hospital of Los Angeles. Dr. Trish is a pediatric pathologist and molecular person. He's also an excellent amateur photographer, by the way. Very nice man. This is the first time this is the first instance of the use of the term Askin tumor to describe this lesion. There have been multiple publications since then. Here is his paper. Blah, blah, blah. The Askin tumor is a distinct entity of greater significance to the radiology of the propensity for bone marrow, and paraspinal area involvement. So that was their take on the lesion. I subsequently, after reviewing a lot of the papers in the literature, decided that actually, I'm not sure many of the people who quoted our paper actually read it. Many of the tumors that were described as Askin tumor were clearly arose in ribs. In our description, the lesion could involve a rib, but the rib was not the primary, not the epicenter of the lesion. Rib involvement was a secondary phenomenon. So these things have been called a malignant tumor of the chest wall, which is certainly true, although they aren't all in the chest wall. Ewing sarcoma of the chest wall, that is probably true, but it wasn't what we said it was. Ewing peanut neoplasm of chest wall, that's probably more accurate. So just being from Baltimore, I like to quote the sage of Baltimore, H.L. Mencken: for every problem, there's a solution that is simple, neat, and wrong. And that's a good standard to go by. So I have subsequently, the World Health Organization raised its head and specifically dissed me. Not recommended. Well, what they didn't recommend was the thing Ewing actually called Ewing sarcoma, which is diffuse endothelioma of bone. They don't recommend Askin tumor. They don't or the term Ewing sarcoma arising in the chest wall, which is weird because the actual heading of this classification is Ewing sarcoma, primitive neuroectodermal tumor. So that's the World Health Organization. I think the Chinese probably share my puzzlement at the World Health Organization. However, Askin tumor persists in the literature. Online Mendelian inheritance in man still says Askin tumor included, and clearly describes Ewing's peanut family. And if you go do a Google search, look at Medline Plus, their take is Askin tumor is a type of peanut found in the chest, which is sort of vaguely true. I find that I'm luckier than Dr. Fritz Brenner, who described the Brenner tumor. He described the Brenner tumor in the ovary as Oophoroma folliculare in 1907, and he subsequently migrated to German Southwest Africa, which I believe now is Namibia, in 1910. 25 years later, someone walked into his office after he'd gone to Johannesburg and said, "Hey, are you the guy that described the Brenner tumor?" And that was the first he'd ever heard of it. So I'm a little bit ahead of him. By the way, this is a great, if you want to know something about people who have eponyms have involved, go to this website. It's all written as all one word. Who named it? Dictionary of Medical Eponyms. It's got some very interesting material in there. I by the way am not in it, so there's no advantage to me. Just as an aside, here's an interesting fellow. This Dr. James Ewing. Made the front cover of Time. Here he is outside of his house. This is a wonderful biography that I discovered while I was trying to get my thoughts together about this case. I don't know where you can find it. It's definitely online. If you look this up, the biographical memoir by James B. Murphy. Ewing was a fascinating guy. You think of him in terms of cancer, but his wife died of eclampsia, and he became very interested in the pathology of eclampsia and many other things. He's not a one-trick pony. This book is actually very well worth reading. So whatever happened to Askin tumor? Well, it got worked out. I don't know if I have this in chronological order or not, but it was discovered that if you did cytogenetics on these tumors, including Ewing sarcoma and other peripheral neuroectodermal tumors, they had a reciprocal translocation of chromosome 11 and 12. And then immunochemistry became available. We did not have immunocytochemistry available to us in 1975. And then molecular patterns have been described with the USFLE1 fusion. There are other fusions that involve the EWS gene, and apparently current data don't really support any outcome difference based on translocation when patients are prospectively evaluated. So CD99 was the first thing that we began to use. This is a very nice article about CD99, which I'm unfortunately becoming the next NSE. It now stains everything. It involves many other lesions besides Ewing's and Peanuts. It's worth knowing about. Other immunocytochemical stains, NXK 2.2 is supposed to be more highly specific, and there is a FLE1 for that fusion nuclear stain that apparently works very well. Cytokeratin, actually, it's described in diffuse adamantomotic variant of Ewing's, but we saw cytokeratin positivity in a small number of just standard, straightforward Ewing's when we were reviewing them in the Ewing study. And periodic shift raises its head again. However, I just want to warn you that not all Ewing sarcomas are PAS positive. Here's one of my dogs winning the Terry Group at Westminster. This dog has subsequently gone to Thailand. This is one of my current dogs. This is the Boston New Gryffindor and a Scotty named Moxie. And I think I should have devoted more time to this, but that's what I've got. Can I answer any questions?
Thank you very much, Dr. Askin. That was a very nice talk about the Askin tumor. I don't know if anybody has questions for Dr. Askin.